Hi, everybody. I'm Mo Bhandari from Ortho Evidence, and here we are this evening with an Ortho Evidence news bulletin of sorts with Dr. Zain Chagla. Dr. Chagla, as you know, is an associate professor at the Division of Infectious Diseases, the Department of Medicine at McMaster University. He was last with us 2 weeks ago doing a podcast that has since had a considerable amount of interest. And we have Dr. Chagla here again this evening. Our members and our users are really interested in is getting a sense of what's been happening in the last 2 weeks since our last podcast. And keeping in mind now that the WHO estimate suggests that there are 800 cases of coronavirus worldwide. And I'm just curious, it's such a rapidly changing landscape, and I'm sure 2 weeks may sound like months to you in terms of what's happened. And I'm curious from your perspective, what is new?
So the first thing, as you mentioned, is the epidemiology has completely changed, and so this was a virus that 2 weeks ago was being seen starting to emerge in Europe and starting to emerge in the United States, and those outbreaks have become major outbreaks. So the case counts in Italy, Germany, France, UK, Portugal, and Spain have progressed significantly. The death counts, unfortunately, have progressed significantly, and we're seeing a major outbreak in the United States, where the number of cases in the United States is larger than any other country in the world, including China, which was the epicenter of this outbreak. We're seeing exponential growth in these countries, although some slowing in Italy, which was hit first. And so we're seeing this virus penetrate into communities. In Canada, there has been growth and community spread, and our epidemiology in Canada has been in not only travelers from those areas of the world, but people in the community who have no identifiable risk factors. Unfortunately, we're seeing a lot of our mortality amongst those in long-term care, and unfortunately, these long-term care patients are probably the first sign of some transmission within the community, as they're not obviously in the community very often, so the virus is being brought into these centers and affecting these patients, and unfortunately leading to their demises. So we're seeing spread in every province in Canada, every territory other than Nunavut, and things will continue to progress in that state. In the last 2 weeks, we've also seen obviously monumental changes in the way we do society. It feels like it's been ages that this has happened, but we're seeing monumental efforts to essentially flatten that curve. So to really spare the health system strain of a large number of these cases reporting to the door, and really trying to temper that growth of cases into a manageable resource environment where everyone can get the appropriate care to deal with their illness if they do require hospitalization, critical care, or ventilation.
Can I ask
Go
you a
ahead.
question about that?
Yeah.
So a big issue and a big question that comes up often is, how extreme do you have to be to truly flatten that curve? So, there must be enough examples now around the world where,
Yeah. So
for example, what is considered to be, best practice now for countries that are looking to really take a real serious look at limiting and risk mitigation?
So, I mean, the best case scenario, as we're seeing what happened in Wuhan, where they were the epicenter of the outbreak and went into very, very extreme physical distancing. They essentially tempered their epidemic down to dozens to less than 5 cases a day in some days. So their extremity of social distancing has uh, um, led to a significant reduction. There's a Lancet study that came out a couple of days ago that suggests a 50% reduction in spread from that type of social distancing.
And Zane,
Now,
can I ask you, Zane, like when you say that, can you be a little more specific? Like, does that mean like what, like for example, we're seeing India saying that
mhm,
we're curfews on, people will not leave their apartments, and
mhm.
people will not leave. Are we talking that sort of
Yeah, that was how extreme it was. But mind you, there's differences in society in terms of that population versus
of
ours.
course?
People um, tend to live in communities of housing, and so people are more reliant on other people for things like groceries or coming in, so people can really maintain that distancing in their day-to-day lives,
Right.
versus a society like ours where we're very independent. Even though we can distance within our own accommodations or housing, we still have to go out and do our errands ourselves in that sense. So that the distancing we see in Wuhan is probably not what we can achieve here, but at least we are trying to achieve some degree of it. And again, doing 80% of that probably still has some tempering effects. Where Wuhan saw a 50% reduction in its spread, we're probably going to see perhaps a bit more because we started early, but not those numbers in the midst of the outbreak in that sense.
Okay, very good. And another area of key concern is, in the hospital environment themselves, what big
Mhm.
changes have you seen the last few weeks in the hospital environment? Really from point of view of the healthcare provider, and what measures are they taking in the hospital? And obviously, we represent, in Ortho Evidence, a group of surgeons
Mhm.
and physiotherapists and a number of other healthcare providers. So I'm sure they're quite interested in that.
So, from a hospital standpoint, there's been a certain amount of interest, obviously, in modeling and trying to develop staffing models, care models that predict the worst case scenario. So, where there are too many patients for just the providers that are specialized to deal with them, how to integrate other providers and how to deal with these patients, how to safely transport patients, their every from the inside in terms of even their resuscitation, the ethical considerations around patient care in terms of ventilation and critical care, and offering of resources in those situations, and really just that scale up approach. There's been considerations about personal protective equipment, and so ensuring right patients have right point of contact. And there has obviously been some controversy around this in the sense that every society's guidelines don't line up equally. Everyone's personal definition of what's considered aerosol generating doesn't line up the same. And there's even variation country to country in terms of that. So the definitions from the Centers for Disease Control are very different than the recommendations from the Public Health Agency of Canada. And that again is risk tolerance and best available evidence. Um, so those have been really the big two hospital issues, as well as just models to ensure that the right number of people are caring for patients. So establishing kind of COVID positive areas in the hospital to deal with those patients, establishing centralized teams for resuscitation and intubation, uh, those types of things to ensure that the right people, the seniorest people, and the most calm and skilled people are providing care, whereas the people that are less trained are not providing that care for the sake of them um, having mistakes with PPE or having mistakes with transmission.
And as far as evidence tells us, the virus itself is an aerosol. It's droplet transferred. There's been some
Hmm.
discussion around, oh, it may be able to transfer through air.
Hmm.
Any evidence around that?
So there's a couple of studies that came out that are putting, I would say, that are putting some controversy into that. So the prior evidence to date really dealt with SARS and the risk of transfer in SARS. A good case control study that was done by Mark Loeb with our group here at McMaster that looked at nurses that got SARS and looked at their N95 versus droplet mask. There was no difference in between. And a similar study that was done N95 masks and surgical masks for influenza, where they actually did look at the other human coronaviruses, which aren't very pathogenic, and similar rates between the two groups. So very similar backgrounds. There was a study that came out in the New England Journal of Medicine about a week and a half ago that used an artificial aerosolizer. The point of this study was actually not to see if the virus was airborne, but it was to see how stable it was on airborne droplets and how stable it was on the surfaces those droplets get onto, basically. So the model was not similar to what would be with a cough or a sneeze.
All right.
It was a model that you would see with a bronchoscopy or an intubation in that
Okay.
sense.
Yeah.
So a lot of people took it as the virus is airborne, and certainly it is airborne if you put it through an aerosolizer to
Okay.
make it airborne, but that's not a human model.
Okay. Got it.
There was another study at the University of Nebraska that I think was just printed a couple of days ago that did air sampling and found the virus in air samples. It's important to note that study didn't really say their technique of sampling, so whether or not they picked up large droplets or small droplets. It was very low level RNA that was picked up, so whether or not that was just contamination of the device or the machine. As we know, molecular signatures tend to be very sticky in PCR assays. And when they looked back and tried to culture the virus, they couldn't. And so whether or not you're picking a little bit of RNA up in the environment from shed or dying virus versus this being pathogenic virus. And interestingly, you can look for the same type of literature around things like MRSA or Staph aureus in the environment. And yes, you can pick up DNA of Staph aureus in the air, but it doesn't mean we're walking around the hospital with an airborne mask for people with Staph aureus infections too.
Got it. So that point around the whole concept of masks
Mm-hmm.
and the concept of a community wearing masks, there's been a lot of
Mm-hmm.
discussion. I should say, like in this discussion, probably to some degree may have evidence, may just be rumor
Mm-hmm.
that's built up. But one area has been this meme around saying that we should be wearing masks. The whole community should wear masks. And in fact, we're wearing masks. Everyone.
Mm-hmm.
We're safer. And in fact, they said pillowcases and talking about wearing T-shirts and with
Mm-hmm.
bandanas. Is there any truth to this? Is there any evidence that would suggest that would be a strategy?
So where this comes from is the country, so Hong Kong, Singapore, and South Korea, where the outbreaks were much more tempered and tapered than Italy and what we're seeing in Europe. And one of the excuses is universal masks, which it's hard to argue it didn't play a role, but there were other concepts. They were screening aggressively. There were major travel restrictions. There was actually a lot of use of technology in tracking individuals and contacts. And so that whole bundle of things probably led to a significant number of community-based interventions that brought the rates down. The masks, there is a biologic concept of them for sure, that if you're around, that you're not coughing, you're not picking up people's cough secretions, and if you're coughing, the mask might blunt some of your cough too as well for the environment. um, for us, I think there are resource issues with masks. For people in the community, their donning and doffing of masks also could introduce infection in that sense too as well, if people aren't being appropriate with things. And there is actually an interesting BMJ study that was done a few years ago around this cloth concept, so using cloth or homemade masks. The humidity concepts in those masks, and so they followed nurses around as compared to regular masks and looked at their influenza rates. The cloth masks, especially with the high humidity that was from water, from moisture from the mouth, led to 97% of particles filtering through and a significant rise in influenza-like illnesses as compared to surgical masks in that population. So um, the concept of any mask is better than no mask is probably not there. The surgical masks might offer a little bit of benefit, but in the grand scheme of things, all those other community-based interventions are probably the biggest bang for the buck in terms of
And,
reducing loads in the community.
and there's probably a lot of confounding here too, right? So people are doing
Hmm.
something without adjusting for all the other factors, as you.
Exactly, exactly.
Okay, and maybe just one more thing before we let you go for the evening. And thanks again for all of this.
Hmm.
There's been a lot of discussion in the operating room, uh,
Hmm.
especially among some of our surgical colleagues, around what positive protective equipment they need, and more importantly, the concept of photo disinfection, the concept of UV light decontamination. Are
Hmm.
these potential tools that should become regular in COVID, COVID positive patients, or is that founded in evidence?
So, not necessarily. Remember, we've been doing ORs the way we terminate clean ORs or clean ORs after cases
Right,
is to prevent surgical infections, right?
right,
That is our big thing to do. So
right,
we're trying to prevent viral infections. We're trying to prevent bacterial infections post-op. So the terminal cleaning is enhanced. There is some look at using UV and photo disinfectants as part of this terminal cleans of rooms of positive COVID patients. The jury's still out. I think a lot of people do think it might add a little bit more. But for routine care in a routine case, I don't think it offers a significant amount of benefit in that sense.
sure.
And again, similarly, the biggest thing is just making sure patients going into those ORs are identified with COVID. If they have risk factors or symptoms compatible with COVID, are tested for COVID. and really treating every patient, at least making sure that you do a risk assessment for every patient in terms of the appropriate amount of PPE that you're going to use with them. But we have processes in place for ORs to prevent the spread of respiratory infections. We do lung surgeries on patients with tuberculosis. So, the way we deal with the ORs, the ventilation in the ORs, and the cleaning of ORs is optimized for the spread of infectious disease.
Very good. I can't thank you enough for spending this time with us today. And we'll be sure to touch base with you again, hopefully with much better news as we move. Just one final point. Do you feel in Canada specifically, where we're hosting this particular evening,
Mhm.
right, podcast, are we seeing a flattening? Is there hope ahead?
There's some modeling coming out of BC and a little bit of Ontario suggesting that the numbers aren't as bad. We've had some issues in Ontario with the testing numbers, and so we have a 3 or 4 day lag in that. And so as we're catching up, we're seeing more cases, but that's actually a reflection of 3 or 4 days ago. Um, but there may be some of that. A lot of us are looking at our own internal models and provincial models and seeing how our numbers line up. And so there is early signs of that. It's still much too early to say whether or not this is going to be the progressive flattening the curve or there's going to be an exponential pace. But I think in a week or two, we'll have a better sense of where we are in the curve for sure.
So if nothing else, a bit of cautious optimism, I hope.
A bit of cautious optimism,
Very
exactly.
good. Dr. Chagla, thank you so much and have a good evening.
No problem. Take care.